For many young adults, completing cancer treatment marks the beginning of a new but often overwhelming chapter. While the end of active care may bring relief, it can also surface unexpected challenges, feelings of isolation, fear of recurrence, fatigue, and uncertainty about the future. The daily support of the healthcare team fades, yet the need for guidance remains. We consistently hear from patients that they feel under-supported and underprepared for survivorship, and that they continue to face significant challenges. And the National Patient Survey findings that we presented earlier today further corroborates this. This session, Life Beyond Treatment, Improving the Survivorship Experience, will explore what it means to reconnect with life after cancer, physically, emotionally, and socially. This is such an important topic, and you see that reflected in the fact that 3 of our steering committee members are participating in this session today. So welcome to Dr. Mary Jane Esplin, who is an RN and psychosocial oncologist, as well as a valued member of CRAN's Medical and Scientific Advisory Board. Dr. Esplin will be moderating this last panel discussion of the event. We welcome Robbie Spring, breast cancer survivor and patient advocate, who will provide the patient perspective throughout this discussion. We also welcome Dr. Stuart Peacock, professor and chair in cancer survivorship at Simon Fraser University and distinguished scientist with BC Cancer. Welcome to Dr. Margaret Fitch, RN and adjunct professor in the Faculty of Nursing at the University of Toronto, who has a background in oncology nursing and psychosocial oncology, and Dr. Leanne Trachtenberg, clinical and health psychologist with particular expertise in psychosocial oncology, and in particular with patients experiencing body image-related distress and sexual dysfunction. Welcome, panelists, and Mary Jane, I'll turn it over to you.
Thank you, Cassandra, and welcome everybody. This is also a very important part of the trajectory, and one that you're often left alone with, you and your families and the professionals trying to help patients and families cope with often the residual impacts of both the cancer or the treatment or both. So we're really fortunate we have some national experts here who have had direct experience working in the area of survivorship, that part of the cancer journey, as well as who have participated or led much of the research in psycho-oncology in this particular area. And we're going to have an opportunity to hear from their expertise and some thoughts they have around the current gaps, but hopefully point you to some direction around things that you can do as well with some of these survivorship types of impacts that you're left with. So we're going to start with Miss Spring. You're going to share your story. So you've had breast cancer, and I'm going to turn it over to you. You're going to start us off talking a little bit about your experience as a patient to give us a patient perspective for the session.
Yes, thank you for having me here, and I appreciate how you are integrating lived experience into this conference. It's so important that we share the stories to provide context for what's going on in the system. I always worked in health and life sciences. I have 2 master's degrees, worked across hospital, academia, government, and industry. And then 2.5 years ago, I found myself diagnosed with breast cancer at the age of 35. My breast cancer was only found because my sister had it. She was diagnosed at the age of 43. And hers was only found because our mom had it, who was diagnosed a few years prior in her mid-60s. And so what cancer looked like for my sister and I at a younger age was very different than what it was like for our mom. And actually, at the end of my sister and I having breast cancer, our dad was diagnosed with prostate cancer. And he's still dealing with that 2 years later. So it was 4 out of 5 of my direct family members within 5 years. And going through treatment and getting access to treatment and care for somebody like me who's connected and knowledgeable about the system should have been easy. And it was quite difficult. It took 11 weeks from the time I was diagnosed to the time I received my first line of treatment, which was obviously way too long as a younger person. Even though it was an early stage cancer, it was still aggressive and should have been addressed earlier. I thought going through treatment would be the hardest part. And when I finished chemo almost 2 years ago, my chemo anniversary or ending it will be December 15th, 2 years. So that'll be exciting anniversary to celebrate. Um, Going into that survivorship phase, like finishing treatment, was way more challenging than I thought. You didn't have the structure of treatment, which you kind of have these milestones that you're hitting or these decisions, and then all of a sudden you're just kind of on your own, like left to figure out what life looks like now that you've sort of been in survival mode for all these months. Um, it was a really weird and scary time. My body was in a state of disarray emotionally. I was all over the map. I couldn't sleep. I was a complete pharmacy, taking so many pills, which I still am. Um, and it was like a very challenging world. And the after cancer part is something that I wasn't prepared for at all. And I had heard from my peers a little bit about after being extremely challenging, but I didn't really get it because I was like, but you're done. Isn't it fun? Won't you be celebrating? But it's not, because you're kind of like in this strange body. So even though like my mom, my sister, and I on paper had similar diagnoses, our treatment trajectories and decisions were different. And the after was very different for all of us. So it wasn't like my sister and I we could talk to each other about certain things, but it was very different. I was single, hadn't had kids. She's married with a child. And so we were dealing with very different things and given different advice as well. Um, Consistently between the both of us was a lack of psychosocial support. And I know I had to take it upon myself as someone who it's like researches everything and wants to just fix everything of what that would look like. And 2 years later, I'm still figuring it out. Like, I'm still dealing with side effects. I'm still on tons of medication. I'm still dealing with weird things happening to my body. And granted, I'm in adjunct therapy, which means I'm still in a treatment of sorts on 3 different medications. And that transition is tough. Um, when I found out I needed chemo, I was pushed into medical menopause, which I'll be in for another 3 years. And so in your 30s, it's something I was never prepared for emotionally. I'm still kind of wrapping my head around what that looks like. But it's hard to relate to other people my age and other friends, like when they are having kids or even talking about perimenopause and trying to connect their experience to mine. Like, they are not relatable. They should not be compared. Somebody going through menopause at an appropriate age or perimenopause is experiencing a transition where I not woke up, basically was in the hospital, and 2 seconds later I was given a needle in my stomach, which put me in menopause, and I still receive that needle every 3 months to keep me in menopause. Um, After going through something like breast cancer, you and cancer treatment in general, especially for a woman, um, you're left with no lashes, no brows, no hair. I had a double mastectomy, so my body was different. Then put myself into menopause, my body looked different, felt different, and I felt like a foreigner inside of my own body. Um, Connecting with young survivors was something that helped. And I did that through Rethink Breast Cancer. And I still do that as a key collaborator. Those are my peers. And that peer support that I sought out was essential and still is essential for me to understand what's happening, finding kind of tips and tricks to figure out. And I also do that for other peers through content creation online, through my LinkedIn, Instagram, and TikTok, because of the support that was lacking for me. A big part of that was hair growth, being left with no hair. And my hair was a huge part of my identity. It's still part of my identity. And so, why I launched online content creation was to create a forum to have to track my own hair growth in a way that was more positive, so other people wouldn't be like freaking out online feeling like I did, which was like, I'm never going to look good, I'm never going to feel good. Just showing that there's kind of a light at the end of the tunnel. And I can tell you that there's a strong correlation with me feeling more like me and my hair growth journey too, because those things are intrinsically linked. In the survivorship phase, like there's inconsistent guidance, even with something like Zolmeta infusions, which I receive every 6 months for my bones, and they're important and to prevent spread of global metastases. My peers don't always receive the same advice on whether to receive them or not. Some aren't even in this province, by the way, in major cities. And like whether someone wants them or not, that should be their choice. And I don't know why some oncologists prescribe it and some don't. It's very odd. The same thing with like, and we're talking about people who are on paper having very similar cancer types, even people who have more risk profile than I do. The same thing with like some of my peers getting prescribed tamoxifen, whereas I'm on like ovarian suppression with an aromatase inhibitor. And so that can be really nerve-wracking because it's like, well, why are you being given one piece of advice and somebody else isn't? Um, I definitely have challenges with, um, you know, getting follow-up testing, and scanxiety is a real thing. I went through some recent issues at my hospital with inconsistent communication from the diagnostic imaging department, not having my records in my own hospital there, where I was being told to get a test that wasn't actually referred to by my physician, and um, the staff not having on record that I had had cancer, even though it was the ultrasound mammogram department that's for breast right next door to my oncologist. They did not have on record that I had had a mastectomy. They had no idea. They didn't know I had chemo. They didn't know anything about my treatment, which meant with like 3 different technicians, I had to rehash every single thing that should have just been in my record. And like, I'm still in oncology care, but I was transferred to a survivorship doctor who's wonderful. And I was very excited about it. And now she's leaving to go to another hospital, which means that I have to start over with whomever is going to come in and replace her and build a new rapport. And I'll probably just stick with my oncologist for now because she is wonderful and provides wonderful care. But those are some of the challenges that I'm experiencing, which others are, and maybe they're not able to articulate it. Um, I'd say like reintegrating into life and feeling normal is a challenge. I have fatigue. Um, I'm constantly foggy. My sleep is off. Again, I'm in menopause plus uh, hormonal suppression. But for younger people with cancer, you're in your working years. And you are expected to go back and rebuild life, but you feel different, and your energy is different. And so that provides like lifestyle adaptations and work adaptations, and just a lot of trial and error of what works. And like sometimes that changes. Like every time I have a Zolmeta infusion, like I am down and out for like a week, and then I get sick a week after because my immune system's down. And then if you look at my Aura Ring data for 2 months after, like my HRV and my sleep are completely worse than they normally are, which they're not great to start with. Um, because like my body's really sensitive and affected by all these different treatments. So it's a constant trade-off that you're constantly thinking of, like, what am I doing so my cancer doesn't come back? Um, am I getting the right tests? Am I making the right decisions in my care? And how do I balance that with actually like feeling good in my quality of life? And that's honestly a day-to-day struggle, even still. Like I was at acupuncture like 2 hours ago for like chronic pain, and it's like I'm constantly faced with like what are the best resources, but then also how do I live my life so don't constantly feel like I'm doing wellness. And it's a very hard balance to strike. I'd say continuously like advocacy is a nice outlet. It does give me purpose, and it helps make me feel like I'm helping other people and having a sense of control over what survivorship looks like. And those are some of the challenges that I'm facing. I wasn't provided, I've had therapy and I've taken it upon myself, but I wasn't given the psychosocial support automatically. And if I wasn't proactive about it, that part could easily get lost. So hopefully I summarized everything well.
Thank you, Miss Spring. That's a lot. You did a very, it's very personal, and you outlined a whole lot of different areas that sound very persistent, pervasive and persistent. It's great to see that you're involved in advocacy, and also you found a way to kind of reach out to other people, because there seems to have been so many inconsistencies even within your own family where there were multiple cancers. But
Yeah.
okay, so I'm going to start with let's turn it over to the experts. There's a lot there. So Dr. Fitch, if I can start with you, I'll just throw one question, give you all a chance to answer, either looking at Miss Spring's story or your own, because you've all worked in the field of survivorship and cancer. Uh, Name or describe what you're familiar with, at least a couple of gaps in the current level of services. We'll start with that. And I'll start with Dr. Fitch first, please.
Thank you, Mary Jane, and thank you, Robbie, for your story. You did summarize very, very well many of the issues that I hear from survivors over the years. I want to say that we really are at a point here in the cancer world where we're benefiting from the advances of science and treatment, in that we're seeing more and more individuals who would classify themselves as survivors. They've finished primary treatment and they're living their lives. Those lives may be cancer-free, or they may have controlled disease. But what is part of our experience is that now survivorship is being talked about in ways that it has never been talked about before. And much of what we've learned has come from voices such as Robbie's, where we have heard some of the experiences that people have had to go through, some of the challenges. And I would say, first and foremost, the survivorship population is very heterogeneous. There is a wide range in terms of the kinds of issues that people are dealing with. And some have few, but some have many. I was involved in a national survey where we had more than 13,000 responses. Now, a mixed group of survivors. But the two issues that I would want to share with you, many were surprised that after they finished their treatment, they still had all of the challenges they had. They found recovery was perhaps slower than they anticipated. They didn't know quite what to expect. And yet the changes in body, such as Robbie was talking about, they had to adjust and find a new way of doing things, or a different way of doing things. Sometimes it was eating, sometimes it was bladder and bowel, sometimes it was mobility. So just being surprised with what was facing them, and having the physical changes and needing to deal with those physical changes, and really longer than they expected in the beginning. So that recovery period was a challenge physically. And then I think one of the other things that has stood out is the difference in people saying, I'm ready to carry on with my life, but my family are not. They're still protecting me and holding me back. Or the other side of the coin, where people are still feeling a little fatigued, they're having difficulty managing, and the family's saying, get on with things, go back to work. It's time for you to go back to work. So I think those will be the two areas that I would mention, one physical, one emotional, just as challenges that are shared by the survivorship group.
Okay, thank you, Dr. Fitch. And you could see in Robbie's story, she touched
Exactly.
on both of those areas in more than one way. And so thank you. Dr. Peacock, are there a couple of issues that you think are really important to identify as current challenges or gaps in the system that we have right now, or that you're noticing in your work, or in Robbie's story?
Yeah, thank you for that. Robbie, thank you for sharing your story. As always, it's very brave to be this open and vulnerable, and I can't imagine what it's like having so many people in one family going through this at the same time. That's an awful lot. So congratulations on how you're doing this and handling it. I'm going to pick up because one of the things that I noticed about what Robbie was talking about, which is common amongst cancer survivors and particularly younger cancer survivors, is most of the questions or issues that she was discussing there, I would think of in terms of quality of life, psychosocial support, very telling, particularly again with early onset cancers. If you're quite young indeed, an adolescent, young adult, you're talking about forming identity and notions of self-worth and the like, and Robbie's experiences there really resonate with a lot of people about sense of identity and the changes you're going under. So I'm going to start with the psychosocial end of things. I think we understand now that there are many varied psychosocial needs. I see very regularly with the early onset cancers that psychosocial support is much more of an issue than perhaps some of our older patients. And that maybe reflects societal changes and generational changes. But we are clearly, I think, in many jurisdictions in Canada, dropping the ball on psychosocial support. And we all know and worry that when we've got bad economic data, that's one of the areas that it's easier for a government to look at to say, we might need to spend some money elsewhere. And that's a real worry because that hasn't changed. The other thing I want to point out, or the other area where we've got big gaps, is around care navigation. And we made huge strides forwards. But survivorship's a tricky one as well, because probably you're looking for a shared care type of model where it's a combination of the patient, the survivor, their family, a family practitioner, if they're fortunate enough to have one, and whatever contact they still have with the cancer system. And that's very variable for survivors as well. So finding your way through that system is incredibly difficult. Robbie mentioned that, this is her area of work and she still finds it difficult. We all on this call who work in the health system have those challenges, and in cancer it can be quite difficult indeed. So finding your way through the health system and working out who you need to be talking to when, and who might be able to help you with different types of problems, that navigation piece is critical, I think.
Okay, thank you, Dr. Peacock. And you really underscored too that I would think a sense of isolation, like the younger population. Some of the services we have are probably geared to different populations, or as you said, you and Mark said, so heterogeneous that it's not always a fit, even if they find them. So there's certainly unique challenges with our younger populations. Dr. Trachenberg, I know you your PhD and postdoctorate work was actually in breast cancer with young populations of women. So you've also worked directly in this area. What would you add to like a couple of chief current gaps or challenges in the way we offer services now for our patients?
I think the first thing I want to do is, again, everyone's done this, but just acknowledge Robbie's story and how important it is to hear your story, because so much of what you shared is what I hear all the time in my private practice. So it's just so important to have your voice heard. So I just wanted to reiterate that first. But in terms of some of the things, both in terms of my past research and clinically, in terms of doing, individual therapy, with survivors, I think the two issues I want to hit on is something that I think Stuart gently hit on, which was identity related concerns when it comes to young people. Who they were before their cancer doesn't mean that that's who they are after going through something this traumatic and this difficult. And it's really hard to understand and navigate what that looks like. And when you're a young person, the added challenge is that many of your peers aren't going through the same process of self-reflection or understanding. And so it's a very isolating and confusing time and experience. And that's why, it's wonderful to be in a room where people are advocating so much for psychosocial support, but that's why psychosocial support and having the space, whatever that looks like, whether it's peer support or therapy group support or individual therapy, where I get to see lots of folks, having that space to really process who were you before your cancer and who are you now, and what can we take with you from who you were before your cancer experience, but also, are there new things that you've learned about yourself through this difficult experience, and who can you become today? All of those elements are really important in terms of identity related issues, I think. So that would be one issue that I would want to bring up. The second issue that I of course have to bring up, and I think Robbie also acknowledged it really well, was around body-based changes, regardless of the type of cancer you may have. And I think, by the way, bringing up your hair is a really powerful one, because hair for so many, well, both women and men, but for women is such can be a very powerful connection to how we feel in our bodies. And many people don't actually realize that before going through a cancer diagnosis. But body-related concerns, or body image distress, put more generally, is a huge issue that extends beyond what maybe most people would even consider to be body image. Body image doesn't just mean focusing on just our superficial appearance, but how we connect to our body after going through something so challenging. And I think there are so many different layers of what it means to feel so disconnected from our bodies and notice these drastic changes in our bodies, and learn how do we slowly over time start to feel more and more connected and embodied again, is just so important, such important work that whether we realize it or not, we have to start doing as we start to move more into the survivorship stage. So to me, those are two really huge pieces that are not always discussed and extremely important in survivorship.
Okay, thank you, Dr. Trachtenberg. That's, the identity piece you saw, and I wanted to point out, I know this is an example with Robbie with breast cancer, but the body image changes certainly are just as prevalent with all the other cancers, or men or other gender as well. Like, it's this identity piece and the impacts of these treatments, that leave residual impacts on the person and the body. And, sometimes patients will say directly, I feel older. And certainly in Robbie's case, she talked a lot about menopause, but people will often say, they're not older, but they feel older because there's been so much change happen. So let's do a round again. We're going to those are all important gaps or issues, and they're big challenges. And Robbie, you did a really good job saying they don't go away very quickly. They're very pervasive, and they're very persistent, and sometimes several years, pretty longitudinal challenges. Let's turn towards what are some resources, or what can people do? What can the individuals or families do? What's available either that might help now? And what types of interventions or services do we need to be thinking about to improve? Because this conference is a lot, Philomena, is a lot about advocacy. Often these conferences that Crane hosts are around trying to advocate to policymakers and research to stimulate change in the system. So let's go around again. Maybe this time we'll start with Dr. Peacock. Anything you can say around either what people can already do with what we have, and then what would your thoughts be around what we need to do in our services to really make a better system?
Yeah, they're really tough questions to answer those.
I know, it's okay.
I'll start with the last one. I'm becoming convinced we are doing a lot of work on shared care models for individuals, both going through active treatment for cancer and afterwards into survivorship in the long term. And I do think that that's a good way forward. So this is a combination of the patient, their families, if they have a primary care physician, and other members of their healthcare team working together to come up with a plan. And it involves an element of self-management on the patient and survivor's behalf. We've always had self-management, but it's never been well defined. It's never been kind of evidence-based and the like. The family, when somebody has a serious illness, the family is there as their support mechanisms and do all these wonderful things to help. But I think in the longer term, what we're going to need is to see more of this kind of better evidence base for shared care models and empowering patients and families to be part of the care process. That also will help with some of the challenges within the health system. The other thing I would say is the access to care is so variable in Canada because it's a provincial territorial jurisdiction. There's tremendous variation in all kinds of countries and jurisdictions anyway. I did want to go back to the adolescents and young adults. Here in British Columbia, we don't have a dedicated clinic for those patients. We are trying desperately to create one. There are other provinces in the countries that do have AYA clinics, and they're fabulous examples, some of them. So I think we do need to, in a number of jurisdictions, look very closely at dedicated clinics for new patients diagnosed with early onset cancers, but also looking at the kind of models for follow-up care and survivorship for those individuals, which I think is slightly different to an adult population, for example, or an older adult population.
That's interesting. So Dr. Peacock, or anybody actually, what are your thoughts? Do we know why the access is so variable across the country? I know we're a big country, but why are provinces so different? Like, I wonder if it would be helpful to sort of, what is that about? Why do we have so many variations, across provinces? What is your perspective on that, or any of the other experts even?
I'll offer two brief thoughts. One, I think a lot of this is political in Canada. One of the observations I have is that the politicians are more closely involved in the provincial health systems than they are in other countries. And the political priorities are different to health system priorities. So I think what you see is the health system getting buffeted a bit more by political priorities in Canada than you see in some other countries, where it's left more to the health system to make some of these decisions. So something as niche as an AYA clinic in cancer will probably not resonate with a lot of politicians in a lot of provinces. And it's a hard message to get across about why this group is very important. The other thing, in all of healthcare, we have tremendous variation in practice. Different healthcare providers interpret evidence in different ways. Things are set up slightly differently. So we do see these wide variations. And sometimes those variations in care shouldn't exist. And sometimes it's just natural process of each patient is different and each patient is handled slightly differently.
Dr. Trachtenberg, before we move on, or Dr. Fitch, do you have anything to add to that about this variability that you've noticed as well, or anything to add?
Well, certainly in terms of my experience working across the country, I have observed the variation and different decision makers, different priorities, different budgets available have all had an influence. And it's almost as if when the economics are very good and there's lots of money, then you see a range of services. But then when the economics take that downturn and there aren't as many dollars available, often it's the psychosocial care that gets dropped out. The social workers, the psychologists, the psychiatrists, the programs that are specialized programs, those are the ones that fall away. And as Stuart has said, I think the decision makers, the political priorities really do influence what we're doing in healthcare and cancer care.
Okay, and it's not as if it's going away because, they just released all those statistics recently. People are living longer in general, with many of the cancer survivorship's gone up. So, these types of residual impacts are going to keep going on, right? It is something we have to think about. Dr. Trachtenberg, do you have anything to add on that? Or I'll ask you the other question around what can people do now with what we have to deal with some of these issues, such as Robin described? Or in your mind, what can be some priorities at the services that we have to really think about in terms of enhancing the services that are in a gap?
Yeah, these are all really good questions. I think I very much agree with what has been said so far in terms of the impact on political situation. I don't want to get too much into it, but even the College of Psychologists right now is going through its own shifts as a result of some of the politics within Ontario. But regardless, I think the one piece I just wanted to add was around there's still stigma. There's still stigma in my mind around differences between physical health and mental health. And as much as we've come so far and done so much, and I've seen it over the years, it still persists, and that's part of, I think, why this happens. But to answer, I guess your next question was more around what needs to be done, or what I I think a few things come to mind, and I think they've been brought up perhaps in other sessions, so I won't hammer them too much. But I was listening in on another session, and I thought it was very clear that time is a really major challenge in the hospital setting. And so it means that sometimes the survivorship care or psychosocial care can't always be done in the way that I believe it should be done, at the pace it should be done, in the hospital setting. Sometimes it either needs to be done, sometimes it needs to be taken outside of the hospital setting, and sometimes it needs to be done as sort of an extra or additional support or group support. So in my mind, the things that I think about are more more virtual peer support group options specifically for the young adult population, because that will ensure that more young people are getting their voices heard. But I also think, again, I'm biased as a psychologist in private practice, that having the hospitals understand the resources that truly are available outside of the hospitals is so important to the psychologists and social workers that have the expertise and experience to provide the care that many patients are looking for and don't know are out there. So I think it's also about more education about to the hospitals in general about what really is available outside of the system to take away some of that pressure.
Okay, great. Thank you. Dr. Fitch, what do you think people can do now with some of these issues, or where do you see some priorities that we need to get to sooner than later in improving our services?
Well, I'd like to pick up on the theme of working with the community. I think there are options available for forming partnerships between the hospitals and the outpatient settings and the community, and making it very easy for the healthcare providers in the facilities to know what's available, as Leanne has indicated, but also then to make the referrals easy so that people know what's available and how to get in touch with the community-based agencies. I think that the community-based agencies have programs available, and the issue is for survivors to know about them, to actually know how to get in contact, where the programs exist. And I'm also thinking about some of the comments that, again, in another research study with survivors, with young adults, we asked, what do you want to see by way of improvements? And they've said, first of all, talk with me, talk directly to me, not to those around me, plan with me, make sure that whatever is going to happen is for me, is tailored for me. And thirdly, create programs that are directed toward my age group and the issues that I'm concerned about. So I think there is a call to action there for community-based agencies to actually create the programs that are necessary, and the call to action around healthcare providers in our hospitals and outpatient settings to learn what's available and make it really easy for people to know what's out there.
And I wonder why it is so difficult that people don't know. I mean, why aren't people communicating this kind of information, like, the hospital settings or the outpatient settings, just so that people know, what are some examples of a community service? Or Robbie, if you've accessed any of them, can you give some examples, any of you, in terms of what that might look like what is already there, so people know?
I mean, Wellspring's available. My challenge with Wellspring was a lot of the programming I went to. I did go during the diagnosis process and not survivorship. And a lot of the people, most of the people were a lot older than me. And I found it really hard to go to those programs and relate to somebody who was retired and talking about their grandchildren when I was going through a breakup, egg freezing, and then, facing menopause. I just couldn't be there. It was upsetting. It wasn't, yeah. And then I think there might be some support at the hospital. Like there was a group for younger individuals that was like once a month that was run by the physician's assistant, like a younger program. And I went a couple times, but it was a lot of people who were a couple years out from treatment. So when I was in treatment, it just wasn't a fit at the time because, like, with the whole like young cancer journey and then into survivorship, you kind of need the right support at the right time. It was the same thing, like Rethink has a sex and body event, which is wonderful. But I went to the first one on the day I found out I needed chemo, which was the same day I was put into menopause. And then I'm sitting there, it's extremely traumatic because I like remember hearing about all these things that I wasn't actually prepared for that were going to happen to my body. Um, and so now I can go to that event and I can participate, but it's catching people at the right time and through their cancer into survivorship journey. And that's a tricky balance to have with a scattered healthcare system. And so that was my experience. Obviously, CCRAN has resources for young individuals as well. I didn't find anything, but that doesn't mean it. Those were the things I found that just didn't work for me, but doesn't mean that it wouldn't exist.
So Wellspring is known not by everybody though, but and not everybody, correct me if I'm wrong, does Stuart, I mean, does everybody have a Wellspring? Do all the provinces, those happen to be in bigger cities. I'm not
Yes.
even sure every province have them. Although I think a lot of Wellsprings, I'm not sure if I'm right anymore, but they were doing a lot of virtual programs, which could be helpful,
Mhm.
like
They
people that
do.
aren't able to come into a city. But that's not across Canada, is it? I know, like Wellspring, does British Columbia have Wellsprings? Stuart, I don't.
I don't think so, but I
Yeah.
could be wrong, or I'm not sure. We have an
I think
organization.
Edmonton does. Edmonton and Calgary. I think some, Alberta has some, but okay. Well, Phil's nodding. Like you guys know more. I can't keep up who is. So there's Gildas Club in Toronto. That's another place where they were offering some program. Anything else that might be a community kind of program for patients?
There's also Young Adult Cancer Canada
Yeah,
Yes.
as another great organization. Yeah.
And
and
Crane Phil, like organization, you know that Crane, I'm sure you advertise. She's a very big advocate. So this is a wonderful organization for offering information sessions, psychosocial sessions, one-to-one peer support, which, you know, I've had patients really benefit who feel connected and you navigate, help them navigate through the system and you're national. Crane is national. So organizations like this are more and more offering outreach and actually what I would consider direct support interventions, really, that are helping address some of the gaps. But is there anything else like anybody can think of that I may not know about?
there's one thing I wanted to pick up on actually. So in BC, I work with an organization called Inspire Health that does a lot of very similar things. I think this is a fascinating conversation around the community-based approach because one of the things we have in the background is when we have nonprofits or the government offering these programs, quite often it's certain ethnic groups and certain levels of education and socioeconomic status who access those services. Essentially, we tend to find it's white women who have a good education are very engaged with those types of services. So this community-based approach is tremendously important. One of the things we're trying to do in BC through Inspire Health is work into different communities. We've moved into Kamloops and Kelowna, but more specifically, we're looking at South Asian at the moment because we have very poor take-up of these services in the South Asian community. And we're trying to figure out what we need to do better to improve access in particularly large ethnic groups within the community. And I think that community-driven approach actually is really gaining some momentum right now because there's no way we can work with the South Asian community if it isn't being driven by the South Asian community as well.
Yeah, good. Margaret, were you going to say something?
Well, I was going to say that the Canadian Cancer Society has a directory, and that directory pulls together all of the various programs that exist. So that is a route that people can actually use to search out programs along the way.
Good, that's true. That's good to know too. Okay, so I'm going to turn on, let's see what we're getting from the audience so that I can open up. Question, Robbie mentioned, this is from the audience, Robbie mentioned that she accessed psychosocial support, but the onus was on her to attain these services. How can survivorship psychosocial care be better embedded into the system? And can dedicated early age onset cancer clinics play a role here? I'll just open it up. Whoever would like to take that on.
I mean, I would have liked that. You can pipe in.
You had to find out everything, kind of, you went trying to figure it out on your own. So, can dedicated early onset. Well, how many age are there? A lot. I don't even know, and I should know. Are there a lot of early age onset actual clinics? Because to me, a lot of my patients are just thrown in with the mixed bag of patients in their services. So I don't know how many early age clinics there are, but maybe that's going to grow because this is becoming a very important population that's being recognized.
I think there's probably 4 or 5 of those clinics in Canada currently, and they might look at 0 to 39-year-old at diagnosis. But you're right, it's patchy. The number will grow, and we're seeing this now in the global media as well, because the incident rates are climbing on a number of different cancers in younger people. So I think you're on the money. It's patchy right now, but hopefully it'll become more important having those clinics.
I was going to say the same thing, that in fact, there are very few dedicated clinics. And the reality when it comes to clinics being formed, established, or launched, it's often because one person, one healthcare professional has taken leadership. And it's not as if the system has said, we need this.
Yeah.
So for me, the advocate voice is so important in terms of moving the decision makers forward in terms of creating special programs.
Mm-hmm. And you all mentioned before too the idea that, you know, health professionals need to be more educated to know what's out there. They play a very, you know, they're front line, they're working with patients and families so that they know more about where, like, as you said, do better with referrals. Can we do better with even that? Like, so the people, the onus isn't just on the person and their family trying to figure it all out, because not everybody's going to be on the internet and doing their own research and even asking around. It's very intimidating. Okay, I'll move to another question. Survivors and their families are often surprised about the levels of anxiety and depression that can persist and the ebb and flow that happens through survivorship. What opportunities are available to improve patient education about what to expect, you know, during this phase of their cancer journey? It's a good point. Open to anybody.
I can't help but think about the newness, and I think of it this way, the newness of survivor phase, and just our ability to talk about it, our ability to understand it. In the whole history of cancer care, it's new. And so we are facing challenges in terms of getting the word out. I think that maybe partnerships with journalists, with newspapers, with just trying to have more articles available in the public domain and more education of the healthcare professionals, yes, because even they need to know about the survivorship phase. It's new in many ways for folks who are in the cancer centers within those 4 walls. Sometimes thinking beyond those 4 walls is a challenge.
Mm-hmm, mm-hmm. Anybody else want to add to that?
Yeah, I think Robbie touched on this very nicely as well, because you get to the, in inverted commas, end of treatment, and you want to kind of brush your hands and go, right, I'm done and I'm out of here. And as Margaret's saying, this is not well known yet, that there's a whole bunch of other things that happen later on. And as you said, it's very variable. It goes up and down. I think this mental health is tremendously important. You're absolutely right. And the other one that goes with that I find surprises a lot of patients is the lack of energy. And that will have a huge impact on your mental health as well. So, you know, we do need to do some advocacy around this, about lifelong supports for some individuals. It's not everyone. and it comes and goes at different points. But I agree with Margaret on this. When you talk to people outside of this area, there's not a huge amount of awareness. And because this is relatively new, I think we've got our work cut out for us raising the profile of these sets of issues.
You know what's
And-
interesting? Oh, sorry, go ahead, Leanne, go ahead.
I was just going to add, and just to add to that, I think once the education is out there, I think then really it becomes having, even if it's just a 20-minute interaction with psychosocial support, just to give people a small snippet of what they could experience to better understand that there is this whole new world that they need to now navigate, I think is so important. And it really is about advocacy, education, and allowing the patient to have just a touch of understanding. And then again, in the most ideal of world, to then have, significantly more access and time to really talk through what does that mean to them, because it does need to be tailored to each in my opinion, to each individual patient. Go ahead, Mary Jane.
No, that's good. That's a good point, Leanne. And I think it sort of speaks to something I didn't want to lose sight that somebody mentioned, Leanne, I think mentioned stigma. The other thing is, when I was hearing Stuart and Margaret talk about this need to move on, like the acute care, like the treatment's over, this plays right into the individual and family response where somebody is receiving a lot of pressure. You had cancer. Now, sometimes patients themselves feels that way. I've had cancer. They have a desire to, have that kind of black and white time delimit, it's behind me, I'm moving on, which doesn't always match reality because of some of these issues you've been hearing about. But the other thing is all that plays into the family also putting pressure on the person. Your treatments are over. Get back on track. Go back to work. Or not just even just work, the other roles in their identity, how they mothered or fathered, or how they, played sports, or how they did a lot of other things that are impacted by these issues. Family members or friends, loved ones can have a lot of struggle around seeing somebody that's had cancer and dealing with cancer, not kind of in their mind quickly getting back on track, struggling with leftover issues. You're not a patient anymore. You need to get back to who you were, this kind of idea, right? So I think, our system plays into that by saying, no, you're released. You can come back in 3 months or 6 months or 5 years or whatever. Meanwhile, the person's still left with all these very challenging issues. Okay, I'll put out another question. How does the survivorship lens need to change systemically with the rise in these younger populations, that diagnosis? Looking at a lens of a younger person with sometimes they have 50 to 75 years to still look forward to. We likely won't have time to address all the questions. So, okay. So, but anyway, looking at this, that's an interesting point. People are living longer with cancer. And you're going to be living longer sometimes with some of these challenges that Robbie mentioned are very longitudinal or even permanent, like menopause, or, whether you have children or not, or body image change, or sexual. Nobody's mentioned yet too much about sexual functioning. That's another quality of life issue that is not always addressed in our healthcare system. Anyway, what do we need to do? Because thinking about that longer term trajectory, we don't really look through this younger population lens very well. Anything we should be doing more there?
I can't help but think there are a number of things we need to be doing. First and foremost, we need to continue our research. We need to continue understanding what the long-term issues actually are and how they manifest when they appear, and then studying interventions that will actually help. We need to do far better in terms of learning about them as healthcare providers, but also then sharing with individuals about the possibility of long-term effects. So not just saying your treatment is over, carry on, but rather let's, as Leanne was saying, let's talk about what could possibly be. And then I think the other issue is creating the kinds of services that could help, and letting the public know that those particular services are available. So to me, it's not just one solution, it's a number of solutions.
Mhm. Yeah. Anyone else want to add to that?
I think, up until fairly recently, there was this terminology that adolescents and young adults in the cancer field are the lost tribe. And I've never been sure whether that's a useful kind of bit of terminology, but what we have seen in the last 10 years is a global recognition that younger cancers are a thing. They are an important public health problem. They're an important population health problem. So we have much more momentum now than we did 10 years ago in this area. So I think we're making some good strides forward. I wanted to add one little thing on top. When I run into AYAs and talk to them, this peer support thing is tremendously important to them. And Jackie Bender's done some tremendous work over in Ontario on peer support programs for adolescents and young adults. We also run peer support programs for older men who get prostate cancer. This is just my personal opinion. I think they definitely have value, but with a younger population, the value is multiplied by 10. So looking at this kind of peer support approach, I think is well worthwhile.
Mhm. Anyone else have anything to add on that? Things we need to still do. I agree to more research and documenting all these longitudinal issues. There's quite a bit in the literature. We still need a lot of good intervention research, I think.
I would just say that that perspective on quality of life and what that means for a younger person is huge, and balancing those choices, because I'm battling basically like everything's focused on like the cancer not coming back, but that also might cause other long-term health issues, cardiac issues that could affect longevity too. And so it's a balance of like looking at the person as a whole, and cancer playing into that. That's really needed, because I'm again doing that on my own, but it is a struggle to be like, what's going to be the best for me in the long term, whole picture, not just piecemeal of like, I had a hormonal based cancer, so we must attack the hormonal based cancer.
Right. Well, we have 2 minutes, and I want to make sure that we thank our esteemed panel. Robbie, you did an outstanding job. You documented, I lost count how many things we were writing down. You really hit all the big ones for sure. And I'm sure that that resonated with our audience a lot. And I want to thank Dr. Peacock, Dr. Trachtenberg, and Dr. Fitch. These are national and international leaders that are actually doing research and working in the clinical realm and policy realm. Often, a lot of you have, Mark's been one of our pioneers in psycho-oncology. So you've seen change for a while, and then we're still trying to do changes, but the research is important, and a lot of you have contributed to the research that's available. Phil and Cassandra, like, how I feel about this organization. I'm big on peer. I remember the day, Margot, I remember this because we're, I think, a bit older. People used to really struggle with peer support. Like they used to have is peer support even part of psycho-oncology? And I could tell you some prominent figures didn't think organizations and peer support should even be part of the continuum of psycho-oncology. There were like major debates in that. And I always felt and said, we cannot do it all as health professionals. There are not enough of us. We don't have enough money in the system. And these types of community-based organizations, which is one of the reasons Phil spearheaded this, was because of gaps in service, because there needed to be more advocacy, but also programs that, we can't possibly fund all of them. So I think I agree. And it's really good to hear so many experts just talk about it. Like this is just to be expected. They're part of our cancer care group. They're part of our community. So I really like to hear about these shared care models. It's a very different time than say 20 years ago. So I want to thank all of you, Cassandra as well. And we're at 5 o'clock. Sorry, Phil, I'll turn it over to you, but I think we're finished. Thank you very much for having us all. And thank you to all the participants that registered for the conference, including 4 o'clock on a Friday afternoon when it's pretty good weather out there, at least in Ontario.
Thank you so much, Dr. Esplin. I think you've said it very well, and certainly that's a wrap on our 2025 Early Age Onset Cancer Symposium. So thank you to our audience members who stayed with us and experienced this awesome event. And I'll hand it back over to Philomena to provide concluding remarks and express Cran's gratitude.